All right. Hey, everyone. Hello, hello. Welcome back to another Carcinoid Cancer Foundation Facebook Live program. My name is Rain Bennett. I'm a filmmaker, and I've been working with CCF for almost 10 years to create video content, whether it's a produced video or live video like this on Facebook. And they all are trying to achieve the same mission, which is to spread awareness and education about neuroendocrine tumors. So this is a special event that we have today. And first of all, before we get started, I want to say thank you so much to Sun Pharmaceutical Industries for their sponsorship of this special Facebook Live program on carcinoid syndrome and managing breakthrough symptoms. Okay, that's what we're going to talk about today. So before we get started, a quick disclaimer. I want to say that the opinions expressed by the guest presenters, as well as the questions asked by the audience, that you all at home, haven't been created or suggested by the sponsor of the program. And CCF does not endorse nor promote any of the views, opinions, or information during the presentation. Audience members, again, that's you all at home, should not rely solely on the opinions or information expressed by the guests and should seek the guidance and direction of their own physicians and healthcare providers regarding any choices they make about their health or treatments. So that last line is really the takeaway, folks. We're going to try to give you some good information with this unique program today, but we don't know your specific case. And so by all means, any decisions you make or thoughts of decisions that you might make, please discuss with your home medical team. So again, today is a really unique program. We have two special guests. Our first special guest is certainly a friend of the foundation, Dr. Lowell Anthony. Dr. Anthony is the chief of the Division of Medical Oncology at University of Kentucky Healthcare, and Dr. Anthony joined the UK Marquay Cancer Center with more than 2 decades of experience in oncology and a special focus in gastrointestinal and neuroendocrine oncology. Dr. Anthony, how are you today, sir?
Very good. Thank you very much for hosting this, Rain, and presenting my patient, Hope Beam, for a discussion to discuss more about the challenges that we face today in managing carcinoid syndrome.
Absolutely. I know it's a topic that people are very, very interested in. Hello, everybody. We see people signing in from all over the country and all over the world already. That is exciting to see. So our second special guest today is Melanie Hope Bean, who I have to take a moment and say goes by Hope, her middle name, like I do. Rain is my middle name, Blakely Rain Bennett. And we discussed this when we were talking earlier this week, that we think that's a Southern thing. Like almost all of my family members go by their middle names for some strange reason. So Hope, thank you so much for joining us today. Tell the folks at home a little bit about your story, your involvement. I know that you were a patient of Dr. Anthony's, but tell us a little bit about your story with this disease.
I was diagnosed in 2002. I actually was on vacation and had a GI bleed. And looking back, I can tell that I had some symptoms, but I mean, nobody thinks about cancer, at 35, 36 years old. But I did end up having a GI bleed, went to the emergency room, underwent surgery, and during surgery is when they found my primary tumor was in my small bowel.
Got it. Well, we've got a lot of time today that we're going to dive deeper into that story. And so for everybody at home, this is what we're going to be talking about today. Carcinoid syndrome, which I know is something that comes up in our weekly programs that we do here at the foundation. I know it's something that a lot of you all are concerned about and want more information on. This is the show for that. We're going to be talking about ways we can manage those symptoms. So send your questions in about carcinoid syndrome, any symptoms you have, any treatments that you think may be beneficial, any questions you have for Dr. Anthony from his medical perspective, or from Hope from her personal patient perspective. I think this is what's going to really help, having both of these perspectives on this particular condition. If we can't get to your question, I urge you to follow up with Carcinoid Cancer Foundation, either here on their Facebook page, you can send them a private message, or at their website, carcinoid.org. So go ahead and start sending those questions in. In the meantime, I want to get us started, because what I like to do, one of my favorite things about hosting any of the videos for Carcinoid Cancer Foundation and any of the work that I've done with them is that I get to learn from this. I'm certainly not a net expert, but I am becoming familiar with nets after 10 years of working in the community. But Dr. Anthony, I want to know, just I don't want to say simple, but let's say a foundational, fundamental overview of what carcinoid syndrome is. That's a term that we hear a lot. For someone who's a new patient, let's break this down on a simple level. How would you describe carcinoid syndrome?
Carcinoid syndrome is really a constellation of symptoms. So being symptom driven, somewhat nonspecific. When we think of carcinoid syndrome, the two things that immediately come to mind is flushing and diarrhea, though diarrhea is watery. So this is not what people might think of occasionally. But in the full-blown syndrome, the diarrhea can lead to electrolyte disturbances, cramping, weight loss, dehydration, syncopal episodes, just a whole other things that build up on the fundamental problem of watery or secretory is another way of that we like to describe it. Secretory diarrhea. It's not the diarrhea you take with stool softeners and things. It's not that. It's not if you overdo fiber or so. This is where it's like a water faucet. You turn it on and it just pours out. There can be pressure behind it and can be difficult to control. The other aspect of carcinoid syndrome being the flushing part, this gets very confusing as well. When a patient shows up in a physician's office and has, let's just say, mostly flushing, if it's a perimenopausal female, it's just instantly written off. Oh, you've got hot flashes. You're getting flushing and hot flashes mixed up. So you obviously don't know really what you're talking about. You're really going through menopause. So that makes it really complex in that perimenopausal period of a woman's life. And in the male, the aging male and even the non-aging male really should not flush. So you'll hear maybe the male menopause. It's just not something that males are programmed to go into flushing, hot flashes or such. So the non-specific nature of this makes it very difficult for early diagnosis in many cases. Usually there's delay of anywhere from 2 out to even 9 years. I think the median is somewhere between 5 and 7. So it really takes pain or nausea, vomiting or bleeding in the case of Hope's situation to really draw attention to saying, hey, this is more than just intermittent GI upsets or intermittent flushing episodes. But when we also think about carcinoid syndrome, we also think about maybe wheezing in a small group, maybe 10% or such. That is well described in the literature of being part of syndrome. And when we control that with the somatostatin analogs and other things, wheezing can be minimized.
Is carcinoid syndrome something experienced by all NET patients or just a small percentage?
So I would say most NET patients probably don't have carcinoid syndrome. It usually takes liver metastases and then a certain volume of liver metastases to predict it. Now, I've seen the carcinoid syndrome in patients without liver metastases, and we think these are probably tumors that bypass the portal system, the spleen there. They like the left ovary, for instance. The venous blood supply of that goes straight into the systemic circulation, doesn't go through the liver. And bronchial neuroendocrine tumors may not have to have liver metastases, but 9 out of 10 of people, or probably even more than that, of people who have the syndrome have significant liver disease.
Got it. Okay. So let's back up a little bit and kind of pick up where we left off from your introduction. So at what point did you feel that you started to experience these kinds of symptoms? Do you remember?
Probably.
And which symptoms specifically were you?
I was having some intermittent bleeding probably for about a year before I had the big bleed. And it was you know, everything from maybe a colitis to internal hemorrhoids to, it just random things. But I really didn't start having an actual syndrome, I would say, probably for a couple years after I was diagnosed.
Is that at which
I
point?
did have some liver involvement, but it wasn't a large amount at that time. I did have some small lesions on my liver, but they really didn't. I don't think there was enough of them yet to start causing the syndrome. I think the syndrome got worse for me in about 2008.
Got it. And is that at what point did you two meet, or you start working with Hope, Dr. Anthony?
So Hope initially was seen down in New Orleans, and shortly after I moved to Kentucky, she continued her care with me. So it's been probably about 10, 11 years or so totality. It's been quite a while.
Okay, so for everybody joining us, if you've joined us a little bit late, we have a unique program today, a very exciting program today about carcinoid syndrome and managing breakthrough symptoms. So if you know someone, which I know there's a lot of people experiencing carcinoid syndrome, this would be the opportunity for them to get some questions across to a patient or specialist. You can share this video right now on your Facebook page. You can comment that person's name or tag them in the comments. Anybody, I see our numbers are growing right now, which is very exciting. And we want to get as many people here as possible so that they can get questions across if they have them. So let people know if you know anybody who is struggling with this right now, that I think this program would be very valuable to them. That being said, we do have some questions coming in, and I want to keep going back to your story specifically. But in the interest of the people attending today, I'm going to get to some questions if that's all right with you guys. And feel free, some of these will be addressed to you, Dr. Anthony. Some of these will be addressed to you, Hope, but both of you feel free to answer them if you have answers. The first question comes from Sherry or Shari. Says, do carcinoid syndrome ever cause itching? Hot flashes, which we did just discuss, but is itching a symptom that is common?
So itching, and the medical term for that's pruritus, is really associated more with histamine. We think of itching being tied in more to allergies. So anybody who anybody that has itching needs to be evaluated with that in mind. Are there multiple allergies to drugs or foods or things? People get very confused with histamine-related symptoms, and I'm going to focus on serotonin-related symptoms. We talked about what the carcinoid syndrome is, but we didn't really talk about the mediators.
Okay.
Diarrhea, it's more serotonin-driven. Serotonin is a naturally occurring neurotransmitter. It exists in the brain. It also exists in the gut, and it's stored in the platelets. So we know those are the big three compartments. If we block serotonin function, we cause constipation. It's part of how what we accomplish with somatostatin analogs and telotrestat. We can decrease the amount of serotonin in the blood that the tumor is making too much of, and slow the hypermotility, increased motility that's caused by too much serotonin. Now, the flushing is more driven by tachykinins. These are neuropeptides that the tumor makes, secretes them, and is totally separate from diarrhea per se. So, and that makes, from our perspective, when we initially see a patient for carcinoid syndrome, we want to see whether the diarrhea predominates or the flushing predominates, or both. We see really patients who have all manifestations of this syndrome. So when pruritus comes about, this is going to be a totally different kettle of fish, really. We would want to be thinking about, is there atopic dermatitis? Are they just dry skin? Is it related to a drug? That's one of the first things we think about. Is it a drug allergy? And then if it's not, then I engage one of our allergists that I work with in the Louisville area, Louisville, Cincinnati, and Lexington. This Tri-City area gives us a fairly large group of people who have different talents and interests. So I engage our allergists in these situations.
Speaking of serotonin, I see a question from Terry. Hey, Terry, that says, can pathology serotonin be in normal ranges and someone still have carcinoid syndrome?
Great question. Serotonin is very helpful in the differential diagnosis. We really have to measure the blood level and measure the 5-HIA, the metabolite of serotonin, to understand how big a problem serotonin has. But the carcinoid syndrome is bigger than just serotonin. So it really depends on what else is going on. If there's a normal serotonin level, then we've excluded that as one of the problems. Now we can start looking at other things. Is it the tachykines? These other substances, these peptides that these tumors make? Or is it short gut? Is it gluten sensitivity? Is it bowel overgrowth? Malabsorption syndrome? There is bile acid colitis. I mean, the list is fairly extensive and has to be eliminated one thing at a time. But if we've eliminated serotonin, we need to move on. We don't need to be sitting and saying, oh, you got a serotonin problem, but your serotonin is normal. Oh, given enough time, your serotonin will become elevated. No, maybe not. It just depends.
Right.
So having a normal serotonin is very helpful in the understanding the mechanism of symptoms.
Yeah, great point. So I wanted to ask you, Hope, this is, we talk a lot about quality of life when we're talking about dealing with this disease. Walk me through we talked about the symptoms that you were experiencing, but I want to know how did it impact your quality of life day to day on the macro scale? How big of a problem and was this creating for you, experiencing the symptoms of the syndrome?
Well, at the time, I did stop working back in 2015, and I worked as a nurse on the floor for several years. And then I changed and I became a home health and hospice nurse. So I was out and about a lot and in my car a lot. And I thought maybe I could manage my schedule in more ways than one, doing that. So, I mean, I functioned fine like that for quite a while. When I was first diagnosed, all my children were still at home, and I was able to, kind of keep everything balanced. But as things progressed and symptoms progressed and fatigue came more into play, and it just got to the point to where Dr. Anthony and I talked about it. And as far as personally, my quality of life has always meant more than quantity. And it was time to slow down and stop working. And it was a hard pill to swallow at first, but I think it's, it was what was best for me at the time.
So you think the work combined with the symptoms that you're experiencing were just kind of adding to it, that extra stress, stress in the body? Yeah.
Definitely.
So for everybody,
and some days I would feel okay.
Sure.
And then some days you don't get out of bed. So it varies, and it's hard to know when one's going to happen. And, it got to the point to where I couldn't get out of bed some days. And when nursing, you don't have that luxury of just saying, sorry, I won't be in today.
Yeah, that's a good point. That's a great point. For everybody at home, I know we have a lot resources on carcinoid syndrome. And so one of the things we like to do on our Facebook Live programs is in the comments on the back end, we'll be adding those. So pay attention to the comment thread, because we'll be adding links for you. If Dr. Anthony refers to anything, an article, a book, a blog, something like that, we can put those links in there. But also we have some resources already pre-made for you. So just pay attention on the side, because we'll be adding those links in the comments. Dr. Anthony, I have another question. We'll kind of toggle back and forth, because I'm really interested to hear more about your story, Hope. Dr. Anthony, Sheila says, have you ever heard of patients with systemic lupus who have NETs and carcinoid syndrome and severe GI bleeds, high gastrin and multiple neuroendocrine hormones that are elevated? Does that make sense?
So here in someone with an autoimmune disease, we really start thinking a little bit differently than the typical carcinoid patient that really is not an autoimmune component to it. So with autoimmunity, we think about having antibodies to the parietal cells that line the stomach that have a critical role in acid secretion. It sounds like that there's a condition called chronic atrophic gastritis that can lead to B12 deficiency and anemia that may account for the elevated gastrin level. Those are things that I'd be thinking about, not NETs per se. Now, could you have gastric NETs in that setting? Absolutely, because we think of gastrin as being the hormone that stimulates the enterochromaffin-like cells. We call those, or the ECHL cells. I know that's a technical term, but these are neuroendocrine cells that are in the stomach lining. And when the gastrin level gets elevated, these ECHL cells, neuroendocrine type cells, will hypertrophy. And we can see little bumps. Very rarely do they result in a malignant invasive type of tumor. But in autoimmunity like scleroderma, when there starts to be elevated hormonal markers, I think there's an explanation for it, separate from a neuroendocrine tumor.
Got it.
I don't want to give her two diagnoses when one's enough.
Yeah, absolutely. Well, hopefully that helps. I appreciate your question. I've got one more, and then I'm going to change topics. But we have someone, Kara says, Dr. Anthony, can you please elaborate on your comment about the left ovary? I experienced flushing multiple times a day, and my recent CT scan had shown significant growth in the tumor around my left ovary.
So the left ovarian vein drains into the inferior vena cava. So it does not go into the portal system that the intestines that filtered by the liver. So what is secreted in that organ becomes systemic. So when there are neuroendocrine tumors in that left ovary, there can be a situation that looks like there's liver metastases, but removal of that left ovary potentially is all that's needed to resolve it. It's a fascinating situation. I'd love to learn more about that left ovary and what's going on there. If there's growth there, it certainly needs to be looked into.
Got it. Well, thank you for that. And thank you, Kara. Hopefully that helped a little bit. So guys, let's talk about treatment. I know there's a lot of options. So Dr. Anthony, I've got kind of a two-part question. First, I just want to know about the typical, traditional treatments as an overview, so we can learn like what the options are. And then after that, I want to dive deeper back into the story with you and Hope about what you decided to use, what you tried to use, if you had to make any changes. So first, what are a patient's treatment options when they are experiencing the symptoms of carcinoid syndrome?
So when somebody is initially diagnosed, we want to know certain aspects, where the primary tumor is, where the metastatic disease is, and then how much is where. So with the syndrome, I'm sort of going to say either the primary tumor is present or it's been excised.
Okay.
The liver metastases are present. And usually the first therapy for that would be the somatostatin analogs. So this was a form of therapy that came about in the 1980s. So by the late 1980s, it became standard, replaced non-specific therapy like Imodium, narcotics for bowel control, cyproheptadine for some of the flushing symptoms and things, or the periactin is the other name for that, and basically an antihistamine type drug. And as we go through, we expect a certain amount of control with the somatostatin analogs. If we don't get it, then we think about resistance pathways and maybe not enough drug in the system. Maybe the depot formulation may not be covering every day. So we really want to go about potentially with local regional treatments potentially in some people. And then we can move on to other forms of therapy. And that now becomes, there's many tools in the toolbox. mTOR inhibitors like everolimus, the telotrestat, the 5-hydroxytryptophan inhibitor to block serotonin metabolism. And we have, for pancreatic, we have tyrosine kinase inhibitors. And then lastly, a couple of years ago, we got PRRT, peptide receptor therapy, which is now going to be referred to as RPT, radiopharmaceutical therapy. And this is an NCI designation. So we're getting away from the PRRT. We're starting to call it RPT.
Oh,
so because it's bigger than just peptides. And that's why NCI has selected radiopharmaceutical therapy.
Got it. That's good to know. I learned something new today. Before we go to Hope's personal journey with this, I have a question regarding the treatment. Laura says, how can I treat carcinoid syndrome if I don't tolerate octreotide or lanreotide? Any suggestions for Laura?
So do you want me to direct that?
Yeah, if you don't mind, and then we'll get back to the treatment that you use with Hope.
So when someone doesn't respond to somatostatin analogs, we really have to sort of focus on what's going on there. What does the gallium-68 dotatate scan looks like? What does the CT look like? Why is there refractoriness? So you're in a small group. So certainly it occurs, but it's a few percentage. And we have to understand what the mechanism might be. So if both analogs have been tried, and is it because the complexity of somatostatin analogs is we may suppress the watery, that secretory diarrhea, but we replace it with another form of diarrhea called steatorrhea. So we really have to delve into what the resistance is. Is maybe the somatostatin receptors aren't being expressed on the tumor, and that would be one mechanism for resistance. That's one of the early things that I would say. When I look at a patient, I look at how bright the tumors are on the dotatate. And if the SUVs are coming in low, and this would be around 2.5 to 5, I probably wouldn't start the somatostatin analogs as one of those treatments. So I really, this is some of the challenges that we face. So don't give up. Just because somatostatin analogs don't work, don't give up. If serotonin is a problem, maybe telotrestat can work. If that doesn't work, maybe the everolimus mTOR inhibitors might work. Maybe local regional therapy to the liver might work. Probably not the radiopharmaceutical therapy Lutathera, because that's going to be dependent on octreotide or lanreotide working. So if that doesn't work, then I'd be really skeptical that PRRT, as we call it today, RPT, as we call it tomorrow, will potentially be useful as well. Really have to delve into it. I'd love to see that patient if I possibly could. These are the challenges that we really face, and we involve multiple people in understanding this. We even include our pathologists now, where we're actually starting to measure somatostatin receptor expression in the pathology lab. You can kind of see that we can't scan everybody that we could obviously do immunohistochemistry on tissue samples. So this is a very exciting time to be in medicine, and specifically to be in neuroendocrinology.
Good to hear. So okay, let's go back to Hope's story here. Dr. Anthony, when you were first treating her and meeting with her, Did you know immediately what type of treatment you wanted to use? Did you have to try a few things and see what was working well? What was your first attempt?
So, the somatostatin analogs is always the first attempt. This is the backbone
Sure.
after surgery. I mean, surgery becomes, and every new patient becomes really number one. But if I see somebody before surgery, I'm thinking about what can I do from a medical perspective to make the surgery safer.
Sure.
And if there is flushing, if there's syndrome symptoms, I'm going to not want the carcinoid crisis to be occurring during surgery. So that's one of the things that we're really focused on in a multidisciplinary group, is to do all we can in people who have significant liver disease to control it before going in and doing an elective procedure. So with HOPE, surgery really was not as elective as we want. Anybody with GI bleeding is going to come to the very top of the attention list and get stabilized and diagnosed in her case, and then stabilized as best as possible. So the somatostatin analogs have been pretty much what we've worked with HOPE, but I think as you'll find out with HOPE's story, a depot formulation just really wasn't enough to control her symptoms. So I'll let her take it from here.
Yeah. So what happened after the, somatostatin analogs? Were you still experiencing symptoms? And if so, what kind of symptoms? What were you going through?
Well, I had been in with another physician before I actually saw Dr. Anthony. And because my symptoms weren't being managed completely with the monthly injection, they changed me over to every 2-week injection, which really seemed like it made things much worse.
Really?
So by the time I got to see Dr. Anthony, he was like, let's go back to monthly. And it didn't make things any worse.
Okay.
And it did, it did help as far as the diarrhea. I seem like I've always had a little bit more flushing. It doesn't really, it's not so much dependent on my injection. As far as the diarrhea and all goes, it's worse about a month or about a week before my injection is due.
Okay.
But back when everything started and I started the injections, we had to play around with the dose, the frequency, sure, and all that. And so by the time I saw Dr. Anthony, he was like, I think you may not need this every 2 weeks. Let's go back to monthly. We'll see how that works. And that, that pretty much has been what I've been on for the last 8-9 years. I do use the octreotide for the breakthrough. And that's been more so probably over the last year or two. About a week before my shot is due, I can tell that it's time for my injection. And then for a day or two after I get my injection, I may use them.
So when you said that they put you with the injections every 2 weeks and your symptoms got worse, or did you have new symptoms added? Or
the diarrhea got worse. The diarrhea got worse. But it was like Dr. Anthony was saying, it was a different, I think unless you have a specialist that understands there are different types of diarrhea.
Sure.
The diarrhea got worse, but it was different than before. I was actually, I think, getting too much of the sandostatin, and it wasn't helping.
What do you think caused that, Dr. Anthony?
Well, one of the wonderful things about the somatostatin analogs is it's a very safe class of drugs. Mm-hmm. Things that we know that it does is slows the gut motility. And that's welcomed in most people who have secretory diarrhea. But while it's slowing gut motility, it's also decreasing the release of pancreatic enzymes this results in steatorrhea. And usually the diet can help control this a bit. We rarely have to put people on enzyme replacement like you would in cystic fibrosis. So we don't induce cystic fibrosis in our patients. I don't want anybody to get that thought in their brains that the minute you start somatostatin analogs, you have to start enzyme replacements. But there are a group of people that have to have enzymes. I won't go into that group, but I think quizzing people about what causes the diarrhea really helps to dissect out this steatorrhea phenomenon, because the stools will float. They'll have a kind of a sour or foul odor, totally different from blood in the stool. And a fatty meal, oil in a salad dressing or such, or deep fried products, can worsen it. And usually there's gas and bloating and all these other things that go along with steatorrhea. So it's really sort of taking that history and then subtracting out, and looking at the labs, that helps also with potassium, magnesium, how that is coming along too. So if it clearly is steatorrhea, we don't really need to induce that. We can back off a bit. And we know that somatostatin analogs in the early part of the dose response curve will cause more diarrhea, more steatorrhea, but then after a certain dose, it becomes flat. But the beauty on the somatostatin analogs is even if we gave her a shot every week, we're not going to cause any irreparable harm. So the therapeutic window for is huge. You really can't get a toxic dose out of it. And so what is good for us is get a smart dose, get the dose that's right, individualized for that patient.
Now, you had mentioned earlier about trying to, I think, prevent people from going into carcinoid crisis. And we actually had a question about that from Claire. What exactly is carcinoid crisis?
So carcinoid crisis is when the tumor is a stimulus that causes the tumor to oversecrete its products all at once. We know that this can happen during surgery or during a procedure in which pressure is being put on the right upper quadrant in most patients. I'll never forget one of my early patients that he presented when he underwent a sigmoidoscopy, and the surgeon doing the sigmoidoscopy just had him roll over in Trendelenburg position to do the procedure, and just putting his own weight in his right upper quadrant called the crisis. And here he is in an outpatient setting calling 911, and he was undiagnosed. This was not someone that even knew he had carcinoid syndrome. So when a patient goes to surgery and the surgeon starts to manipulate the liver or just do things just to get to expose to create a surgical and operative field of work, they may have to put retraction on the liver, or when they go to remove it, they have to touch it and push it out to pull it out. So this is a sudden release. We do know that the things that start with E will produce it, will potentially exacerbate it. So alcohol. Hope, do you ever notice that any wine or beer or anything like that might cause any syndrome symptoms? Do you notice?
I definitely cannot do red wine. Not
What
good at
happens?
all. I flush really badly, really badly.
So that's typical. And so what may happen is the blood pressure may fall too, particularly in the operating room. Now, there are reports in which the blood pressure goes up. That's a very smaller group, but generally it's hypotension, and it may not respond in the operating room. It may not respond normally to resuscitative measures. And this is work that Dr. Pommier has done out at Oregon, University of Oregon. And he's probably done the most on understanding the intraoperative crisis. But ethanol is one, exercise or emotion, epinephrine. It's very common for carcinoid patients to be told, don't take epinephrine during a dental procedure or so, because that could be enough to cause you to flush and to be ill from it. So I think crisis is something that can be prevented, maybe not always, but being aware of it. I have people for endoscopy procedures maybe take an extra shot of their short-acting octreotide before a procedure. And that way, when they get there, they don't have to be asking for a short-acting. They've already taken it. I do find that people whose symptoms are not well controlled with the depot, it doesn't take much exercise or emotional upsets to trigger it. I know those are the people that will really benefit from maybe using the sub-Q octreotide before any stress-related events.
Got it. Thanks for that. Hope, I have a comment from Tanya. It says, that's exactly what happened to me. I went from working in nursing, then home health. I can't find the energy to even get out of bed. So little empathy there with your situation. Let me ask you this. So when rather did you start to feel, if you did, that the symptoms were starting to get better under control? And what do you think was the cause of that?
I think I had to make some lifestyle changes. I
Say more
had
about that.
to slow down. I had to listen more to my body and what was going on.
Where are you now in terms of symptoms?
It's hard to tell. Some days are better than others. Some days, I can get up and feel like I can just conquer the world that day. Unfortunately for me, and I think it's just my personality, I will go literally until I just can't go anymore. And Dr. Anthony and I have talked about this. Balance is not my friend. So he said, and if it works for you, then, it works for you. I'll go for several days and then it's like, okay, today's my day that I just, do nothing. And I had to learn that over time. And I think everyone's different. And like I said, my quality of life is very important. I thought I would be, one of those little old ladies still walking the halls of the hospital, nursing forever. But, you have to let some things go to be able to enjoy other things.
Yeah, that's a life metaphor right there.
Yeah.
It's a life lesson for sure. Now,
that's different for everyone. I
True.
feel like that's different for everybody. So
are you just on the monthly injections, or do you also have rescue treatments, or how are you managing this when on those days when it's particularly bad, like you said?
I do both. I do a monthly injection, and then I have a pen. I was on the octreotide shots that you had to draw up.
Okay.
But now I have a pen that I use. I can use it up to 3 times a day if I need it.
Oh, wow. Let's dive into that a little bit. Dr. Anthony, is that a new offering, a new treatment, and how does that work exactly?
Oh, you never asked, Rain. Octreotide came to us from the late 1980s, as I talked to you about, in multi-dose vials. And you can kind of imagine what this was like for us, having to prescribe multi-dose vials and to teach people how to give themselves injections.
Right.
This was a little bit of fish out of water for medical oncologists. About the only other drug we were using at the time was interferon. I actually had heard stories of patients coming to see me in which other practices would put them in front of an interferon tape to teach them how to do octreotide injections. Here, watch this program on interferon. They'll teach you how to do the injections. So at the same time, insulin was being given by more sophisticated mechanisms, by starting to use it as a pump, and then eventually pre-filled syringes. So this drug came out of the gate with major problems of implementation. So we went 10 years teaching people how to do their self-injections. And I found out usually when people would come to see me in that 10-year period, it was literally about how to do self-injection. So it was pretty easy for me to see patients back then. And then when they would come in after the depot formulation became available in about 1999, so from that period up until probably for another 5 or 6 years until We got everolimus. The only thing I could do for people is to say, oh, the LAR is not working that much. You need rescue. So people would come see me just to learn how to do rescue shots. And you really kind of felt like your oncologic skills were not being challenged that much because you thought a lot of that should have been taken care of at the time that they started their depot formulation, because the octreotide long-acting repeatable, the LAR, is meant to be used with immediate release. You can kind of see 10 years of very struggling, teaching people how to draw up out of a multi-dose amp, to now just come and get your shot and, hey, don't bother the medical staff. They're too busy taking care of, quote, real problems. We're not going to teach you how to do sub-Q rescue. So I literally would just see a whole host of people and just teach them rescue, because this is what they needed the week before their injections are due. Or, some people would take their rescue shots almost all through the month of taking their depot injections. They just found out they felt better. So it really kind of tells us a lot about the physiology with people. It differs between people. Some people require higher levels than others. It's not easily predictable just based on amount of tumor burden. So I think today we've got a lot better flexibility in teaching people how to use immediate release octreotide with this new pen that we've just had since about June. And when it came out, my first reaction was, boy, this has been a long time coming. We should have had it many, many years ago.
Hope, walk me through when it's time to use a rescue treatment. Like, what are you going through when you're like, all right, I need to go grab the pen?
A lot more flushing, diarrhea. Sometimes it may be I even will just get a really bad headache. I might feel a lot more tired that day than normal, but for the most part, for me, I notice it mainly by the flushing and diarrhea.
That headache is probably from dehydration.
How quickly do you see relief when you use it?
Usually I would say within a couple of hours. I mean, you may not feel wonderful, but and I even get like heart palpitations every now and again. My, your heart will beat a little bit faster than it normally does. And that usually settles down pretty quickly after the sub-Q injections.
Good. I just want to take a moment. A lot of the value from these programs that we like to provide it's really about the heart of what we're trying to do here. And I just have a comment from Dorothy. It says, thanks from Canada. You help me not only in information, but you make us feel not alone. And I mean, I'll tear up right now like that just because I feel like I know the importance of that. And I just want to take a moment to thank you, Dorothy, and call that out, because I think that's so, so important. And I've said this time and time again, and I'll continue to say it. One of the things I think is so special about the neuroendocrine tumor community is that it is a community. And I see it every week here when we do programs. I see it within the comments. It consists of patients like Hope, of doctors like Dr. Anthony, of caregivers, of nurses, of so many different people. And that just, I don't know, that makes me feel good. I appreciate it, Dorothy. And I think helping people not feel so alone is why it's so important to share your story, Hope, and why it's so important to share the information that you are, Dr. Anthony. So I appreciate that. Also, I have a message comment from an Ashley Bean Burris. I don't know if you've ever heard of her. Hope.
I know her.
Hope's daughter here. Something must be mentioned about her outlook on life. I love where we're going with this already. Always positive, even when I know she feels bad. I mean, this is a mother-daughter relationship here. I love this so much. Her unwavering faith and sense of humor, along with the amazing doctors, that's you, Dr. Anthony, through the years is why she does so well. Man, y'all are really going to get me to cry here. Tell me about that, Hope. This is something that people struggle with. And if they're fortunate, they struggle with it for a long time. How how do you approach this? Tell me about your outlook on life. I know a little bit, you know, I know I empathize with you about the lack of balance. It sounds very familiar, but how do you approach life given the condition that you have, and what would you advise or suggest as someone else going through it in terms of that outlook on life?
Well, I mean, I've had 19 years to adjust to this, so it's not like I was just faced with it yesterday. And after Dr. Anthony approached me about doing this, I really had to sit back and it brought back a lot of memories and a lot of thoughts. I remember my first visit to my local oncologist, who I love, but I think I was only at that time maybe the second patient he had ever seen that had a carcinoid tumor. I was the first patient my surgeon ever saw, and this is a surgeon who had been operating for 30 years. So my initial diagnosis was shocking. And when I had my first appointment with the oncologist after my surgery, he told me at that point, with the extent of the disease that they found, you have between 2 and 5 years. Well, my kids were all small. They were still little then. They were all still at home, and that was pretty devastating. And I think you go through a period where you're just kind of taking it all in, and then you get in the search mode. You just search for as much information as you can. I also depend on my faith a lot. I didn't feel like I was dying. I didn't feel that sense of imminent, despair. I became very proactive as far as trying to educate myself. I had never heard of carcinoid cancer before. And I had a very, great support system, a circle of friends. We went to a carcinoid symposium in Tampa, Florida. I even went so far as thinking I found a specialist that was in Birmingham and contacted them. And when they called me back, come to find out they weren't in Birmingham, Alabama, they were in Birmingham, England. So, you just try to get as much information as you can.
Yeah.
And I had to really think about, I got to the point to where I remembered the days when I didn't worry every day if I was going to die. I had to get back to that point again. And like I said, my quality of life was very important. I prayed that I would make it long enough to see all my kids grow up. And I've done that. And I have 5 grandkids. So,
Awesome.
And I have a wonderful husband that's very supportive. And, you just have to find what works for you, and what works for me may not work for everybody, and there's no right or wrong answer. Are there still things that I would love to be doing that I know I can't do it anymore? And that's okay, because I can do so many other things that I didn't know if I would ever get to do. So and education and finding a doctor that treated not just your physical symptoms, but what's important to you, not just, okay, we're going to operate, we're going to do this. Dr. Anthony always asked me, how do you feel? Do you feel like you're doing okay right now? There are things we can do, but how are you feeling right now? And right now, I feel okay. I think I'll know when it's time to do something else. And I have done things in the meantime. So I haven't just been sitting on a stick of dynamite. I had my initial surgery. I have had a liver debulking surgery. I had a complete hysterectomy. I've done certain things that I need to do, but it was important that I got in with somebody that knew me, the outside and the inside. And what my goals were. And when it comes time to do something different, we'll go, we'll go down that road. But I think initially you're like, oh, I got to do something now. I need to act on this now, and it's going to be something drastic. But for me personally, you get over the initial shock. Life happens. You still have kids to raise and ball games to go to, and work to be done. And my thing was, I don't want anything to change. I don't want anybody to treat me differently. I don't want anything to change. But looking back, everything changed. Everything changes, but it's not always for the bad. So you just have to find what works best for you.
Yeah. Well, I think that if Ashley is any indication, one thing you've done right is raise those kids. So thanks, Ashley, for being out there and standing up for your mom. Everybody at home, we've got just a little more than 5 minutes left, and we've got a lot of questions. If I didn't get the chance to get to your question, we've had a lot of them today, and we've covered a lot of ground. So again, I urge you to reach out to the Carcinoid Cancer Foundation. I promise you they will get you the direction or the information that you need. If you want to revisit this video, it will live here on the Facebook page. You can come back and look under the videos tab and it will be there. So Dr. Anthony, I'm going to try to cover some ground with some not rapid fire questions, but just get through as many as we can. We have a few about the rescue shots or the pen. So Sandy says, so this pen helps with what symptoms specifically?
So the pen is indicated for symptoms of carcinoid syndrome that are not controlled with the depot form. Now, do you have to take the depot form to take the pen? No, you don't have to.
Okay.
But that's the intent of using it with a long-acting release. So those symptoms would be things like diarrhea, flushing, and again, we've kind of talked a little bit about what those symptoms lead into. Hope talked about the headache and the palpitations, but fatigue. I can tell you right now, if you don't have the diarrhea controlled or you flush all the time, fatigue becomes the #1 complaint. So I think for someone who knows how the syndrome impacts their own well-being, then knowing when to take the immediate release would be when symptoms occur, and we're going to call them breakthrough symptoms because 2 out of 3 people will be controlled with the depot formulation. Mm-hmm. But adding the immediate release will bring that up another few, by another 10 or 20%. So we want to get the blood, we want to make the blood levels whatever that person needs to control symptoms. That's the rationale, is it's a pharmacologic intervention, and the depot formulation just cannot deliver the right amount at every time point within a 30-day period, because as you know, there's stressors, life goes on with those emotional and physical stresses that people go through. That would be another reason to take the immediate release, is to prevent a crisis potentially. Or
good point. Sandra says, do the rescue shots work the same way as LAR for tumor control?
So when we go back and look at the decade from about 1988 to 1998, when we go and look at that decade, people were living about 3 times longer than what they were before. Now, that wasn't scientific. And that was my own personal look at the group that I started following, about 120 of them at Vanderbilt. When I looked at how people did before 1988 and after 1988, I was convinced that that octreotide was more than just a quality of life drug. So by about 1994, it took me about 5 or 6 years to firmly become convinced that this has some anti-neoplastic action to it. Now, the heart of this question, the meat of this question, is that when you're using immediate release, you have to have a timer, something has to go off to remind you to take it. If you don't have a lot of symptoms, and that generally is what would go off, the symptoms would go off. Oh, it's been 6 or 8 hours since my last shot. Now I'm flushing. Oh, I need to take my shot. Well, you don't want that to be the case. You don't want someone to have to rely on symptoms. We want to make people symptom free. So what happened was that when the depot formulation became developed, then we actually proved with the PROMID trial and later with the Clarinet trial that the depot form of somatostatin analogs did give us better outcomes as it relates to quantity of life.
Got it.
The immediate release was quality of life that translated into early indication that it also increased quantity of life.
And the name of this pen, is it pronounced Benfesia or Benfesia?
Benfesia,
B-Y-Z-I-A. That's what I thought. So everybody watching at home, if you are interested in more information on that, we've put the link, as I said, in the comments, so you can scroll through there and find out more information on that. Dr. Anthony, we're almost out of time, but I have one more question. Are there other treatments that are kind of coming down the pipeline that you see for carcinoid that may be beneficial for carcinoid syndrome, or that excites you about, the ability to treat this?
Well, when we specifically talk about carcinoid syndrome, we're really talking about tumor control.
Sure.
We know that radiopharmaceutical therapy is the latest. Now, how is that going to, how are we going to get better than that? Well, we never want to second guess surgery and local regional therapy for syndrome control. We never want to discount that. That's always, that's there, and it's there forever, because that's the physical debulking that you don't have to deal with it. But from a medical standpoint for the syndrome, we're really focused a bit on mechanisms, control, what mechanisms or can we use to increase our PRRT drugs. And that's what some of the work that we're on right now is to put our PRRT drugs on steroids so that we get better cell kill. So immunotherapy, that's been tried. There's not a lot of mutations that we see in these well-differentiated neuroendocrine tumors. So looking at driver mutations that we see in other malignancies, we don't see in this malignancy. The hope for immunotherapy is not what we all want it to be. I think we're going to take time to figure that out. But in the long run, I think we hopefully will have some way of activating the immune system, because we know that's the ultimate way of controlling this disease. Would be like, let's fight from within. So there will be new analogs, new RPT analogs coming along, new mechanisms. There'll be new TKIs would be one of the new drugs that are in development. There's one that's before that got fast track approval, serotonin, that's been developed by a company in China and championed by our colleagues at MD Anderson. So we're going to see TKIs. We're going to see better and improved RPT drugs. In the somatostatin analog agonists, we now use an antagonist. The agonist may stay along a little bit differently. So we'll be looking at radio-labeled agonists.
Awesome to hear. Well, everybody, that is our time for today. I have a comment that sums it up better than I could. Terry says, hope you are a light. And Dr. Anthony, thank you for making sense of it all. I think that sums up our program today perfectly. And I'm really proud of this, because I think it embodies what I would say the core values of Carcinoid Cancer Foundation are, which are one, information, getting you the right information or the direction to the right information, and two, providing community. And I think with Hope and Dr. Anthony today, we achieved both of those. So thank you all for joining us today. As always, we hope that we gave you some answers to some of your questions, some information that would be beneficial. Again, I know we couldn't get all the questions. There was a lot of them today, and that's exciting. That's good. So please reach out to ccf@carcinoid.org if you have any other information that you need. Thanks again to our presenting sponsor, Sun Pharmaceutical Industries. We couldn't do this program without them. My name is Rain Bennett. Thanks for watching. Stay healthy, stay safe, everybody.
Thank you, Rain.
Thank you, Rain.
Bye-bye.
Thanks.
Bye-bye.